Hi everyone and welcome. As I said, as you know, we normally have one of the Family Medicine Academy directors chairing this meeting, but we didn't have anybody available today, so I'm going to do a quick introduction for Dr. Gallagher. You know all of us here, I presume. You know Vicky, who's the mainstay of organising everything from Saudi Commission for the Family Medicine Academies. And Brian has been involved, like myself. Brian's been involved on the IHEAD and the IT side, and I've been involved in the ICGP side since we started working on the Family Medicine Academies a number of years ago, as part of the vision for development of the health services in the kingdom. So because of COVID this year, we've had to make a lot of changes to what we do, and one of the things we've been doing is these webinars, these monthly webinars. So I'm delighted to say that today we have with us Dr. Joe Gallagher. Joe is he is a family medicine consultant, or a GP as we call them in Ireland, but that's different from your GPs. He's a family medicine specialist working in the county of Wexford, which we call in Ireland the sunny southeast. So it's an area where you might get sunshine if you ever come to visit Ireland, much more likely than in some other parts of it. And I hear it's raining there today, so at least we don't have that. And Joe, as well as being a family medicine physician, is also clinical lead for nationally for our college for both global health and for cardiovascular health. And he's here today in his role as clinical lead for cardiovascular health to give you an update on some very common and very important issues that we see very regularly in our practice, and that you, I'm sure, see just as regularly in your practice. So I'm going to hand over to Joe, and you might like to do a little intro for yourself, Joe, as well, if you like, and then we'll get started, okay?
Thanks very much, Molly, and thanks everyone for joining us. It's good to be back again. Last year I did one on multi-morbidity, which I hope found of use, and I've been involved in developing some of the cardiovascular online modules you've been doing as well. And today I was asked to talk about hypertension and atrial fibrillation. And please feel free to put any questions into the chat, and we can address them afterwards. I'm very aware maybe differences about how we manage things in Ireland compared to Saudi Arabia, and it would be great to discuss those and see what the differences are.
Joe, you're muted there. Sorry. What happened?
Must have hit mute by mistake.
Can you hear me now?
Yeah, I can hear you now.
Perfect. Sorry about that. So listen, sorry everyone, you missed my great introduction. So this is great to be back again. Last year I did one of these on multi-morbidity, and it was really enjoyable. And also I've been involved in developing the modules online that you may have undertaken, which involves hypertension and atrial fibrillation. And we'll talk about those today. And I'm conscious there may be some differences in how we manage it in Ireland compared to the Kingdom of Saudi Arabia, and we can discuss those as well. And please feel free to put any questions you have into the chat, and we can discuss them afterwards. I think the first question we need to ask ourselves, why are we here talking about blood pressure and atrial fibrillation in the midst of an international pandemic? We have enough to be doing trying to manage this. And I think it's important to remember that in all epidemics or pandemics, you see this first wave of morbidity and mortality related to the pandemic itself. And you can see here, for instance, in COVID-19. But then and although there may be other waves of the virus, there's also waves of other illnesses. So you then start to see the impact on non-COVID conditions, which are urgent, such as cancer diagnosis or heart failure diagnosis. And then you also see a wave in terms of the impact of interrupted care and chronic conditions, such as diabetes, hypertension, atrial fibrillation, and the effects of that after a period of time as well. And often, the deaths from these conditions can outweigh the impact of other conditions. So, for instance, when Ebola hit West Africa, more people died from malaria because they couldn't access primary care than died from the Ebola itself. It's very hard to balance those, because obviously in a pandemic, you need to address the immediate need of reducing the morbidity and mortality of COVID-19. But I think it's particularly important for us as family medicine consultants to remember that these chronic conditions are still there and can still cause significant morbidity and mortality. It's also important that they can affect your outcomes in COVID-19. And this is a study from the United Kingdom involving over 17 million patients, showing risk factors for severe COVID-19 disease and mortality. And you can see that there are significant effects in terms of these comorbidities. For instance, the worse controlled your diabetes is, the more likely you are to die from COVID-19. And similarly with things such as chronic cardiac disease, you can see here almost twice the risk. Interesting, hypertension doesn't appear to have an increased risk, although other studies have found an increased risk. And even in this study, they found that younger people with hypertension were at significantly increased risk of mortality. So certainly the better we can control chronic conditions, the less likely people are to suffer morbidity and mortality from those conditions. But also if they do get COVID-19, the less likely they are to have worse outcomes. In terms of hypertension, it's something we all see very commonly. And I think it's important to remind ourselves it's a really good predictor of a lot of really bad outcomes: stroke, myocardial infarction, heart failure, atrial fibrillation, and dementia. Really important things for the health system and for patients. And what's interesting about this condition is that this, as a risk predictor, is consistent in all age groups and all ethnic groups. Very unusual for a risk predictor to be this good at predicting so many outcomes in so many different settings, but hypertension is the one that does that. It's also important to remember that when we treat it, we have a significant impact on outcomes. So for every increase in blood pressure of 10 millimeters of mercury, we can see an increase in the risk of stroke by 35% and the risk of coronary artery disease by 20%. But equally, if we get that blood pressure down by 10 millimeters of mercury, we reduce the rates of those conditions by the same amount. And I think this is particularly important in family medicine, where particularly with older people or people with multimorbidity, it may be hard to achieve the targets we see in guidelines, but a reduction in blood pressure of any amount is worthwhile. In terms of atrial fibrillation, and I've found it difficult to find data on how common it is in the general population in the Kingdom of Saudi Arabia, but certainly this European Society of Cardiology guideline highlighted that 1 in 3 of us will develop atrial fibrillation, particularly as we live longer and we have more chronic diseases. But atrial fibrillation is associated with significantly worse outcomes also. You can have 1.5 to 3.5 times the risk of death. Almost a third of all ischemic strokes are associated with atrial fibrillation. A third of people with atrial fibrillation will have heart failure, and there's increased hospitalizations, dementia, depression, and impaired quality of life. So again, managing this condition appropriately will have significant impacts for your patients and for the health system as a whole. I think the other important thing we need to remember in treating these conditions is how long does it take to have a benefit? And I think this was a useful slide I came across, which highlights that although we think of diabetes and lowering blood sugar as something that happens very quickly, in actual fact, to prevent things such as microaneurysms or other microvascular events, you need to treat blood sugars for almost 10 years. Within 2 to 3 years of actually treating blood pressure, you are preventing strokes, heart failure, and death. So really important to know that is having you're really having a major impact on people of all age groups in treating their blood pressure appropriately. So how about diagnosing hypertension? I think one of the really important things with this we need to remember is it's really important to measure it correctly. Certainly in my clinic in Ireland, I could be accused of rushing through measuring blood pressure, putting the cuff on over their clothes, or letting the patient talk to me while they're having their blood pressure taken. But this diagram reminds us we need to be sure the patient is seated properly with their back supported and their feet flat on the ground, that the cuff is of an appropriate size, that it actually fits the arm appropriately and is at the same level as the heart, and that the person's arm is supported also, so that we don't have wrong readings. And just to show you the effect that these simple things can have, for instance, someone with crossed legs, their blood pressure reading may be off by up to 8 millimeters of mercury. If someone is talking while they're taking their blood pressure, it can increase by up to 10 millimeters of mercury. And even something simple as just not having their arm supported or not having their back supported can increase it by 6 to 10 millimeters of mercury. And when we're talking about putting someone on lifelong medication, it's important that we do this appropriately. So these are from the National Institute of Clinical Excellence Guidelines in the UK. They suggest if the first reading in the clinic is greater than 140/90, we should take a second measurement during the consultation. And if the second measurement is higher than the first, then we should take a third measurement. And this is emphasizing the importance of not just relying on one measurement to make a diagnosis of hypertension. We should take the lower of the last two measurements as a clinic blood pressure. And then if the blood pressure is between 140/90 and 180/20, then it's suggested that we offer ambulatory blood pressure monitoring. For blood pressures above 180/20, because that's quite a severe hypertension, they should suggest we should start to treat that. You may still decide to do ambulatory blood pressure monitoring afterwards, but it's unlikely that you will have the blood pressure come down by such a significant amount that it won't need treatment. So start treatment and then do the ambulatory blood pressure monitor afterwards. In terms of ambulatory blood pressure monitoring, as you know, there's 3 readings to consider: the daytime average, the nighttime average, and the overall average. And these are slightly, the normal levels for these are lower than what you see in the clinic, because people obviously are more relaxed when they're at home and out and about. So a clinic blood pressure of 140/90 is equivalent to a daytime reading on the ambulatory blood pressure monitor of 135/85. And equally, if they're doing home blood pressure monitoring, that's also 135/85. So 140/90 in the clinic is the same as a daytime ambulatory blood pressure monitor of 135/85 or a home blood pressure monitor of 135/85. The overall average for the 24-hour blood pressure monitor is 130/80, and that's because the nighttime readings tend to be less, or should be less, in most normal people. So you need to decide what reading you're looking at when you're trying to decide does this person have hypertension or not. And particularly, the National Institute of Clinical Excellence Guidelines used a daytime reading as their cutoff of 135/85, whereas the European Society of Cardiology Guidelines, for instance, use the 24-hour average of 130/80. And so you may see differences when you're looking at guidelines and what level they are recommending, but that's often based on which of these they're choosing as their measure. So once you've done this, you can, as I said, you have your clinic blood pressure, which is elevated. You then use an ambulatory blood pressure monitor. If the monitor shows that the reading is actually normal when you do it, then this is white coat hypertension, which you'll be very familiar with. And although this does not need drug treatment, people with white coat hypertension are at increased risk of developing hypertension later in life and at increased risk of worse cardiovascular outcomes. And the challenge with this in the clinic is trying to know when they come in and you measure their blood pressure, has their blood pressure actually truly risen, or is this just their white coat hypertension again? So these people often need ambulatory blood pressure monitoring on a regular basis to try and determine, is this white coat hypertension or is this actually true hypertension? For people whose blood pressure is greater than 180/120, this is stage 3 hypertension, which is obviously severe blood pressure. And then they have cutoffs and ambulatory blood pressure monitoring on daytime averages of 135/85 for stage 1 hypertension and 150/95 for stage 2 hypertension. And these equate to these clinic blood pressures of 160/100 for stage 2 hypertension and 140/90 for stage 1 hypertension. Once you've confirmed that someone has a diagnosis of hypertension based on the blood pressure monitor, whether that's you've done a number of clinic blood pressure readings, or you've done an ambulatory blood pressure monitor, or someone has measured their blood pressure repeatedly at home, the next question is, have they actually damaged any of the organs in the body? So this can be done with some simple tests. So a urine dipstick to look for hematuria and proteinuria showing kidney damage, checking a renal profile blood test and an estimated glomerular filtration rate to determine is there any kidney damage. Also looking at other cardiovascular risk factors such as a lipid profile or fasting glucose or HbA1c to help determine their cardiovascular risk. A 12-lead ECG to look at do they have any signs of atrial fibrillation or left ventricular hypertrophy, and then also examining the fundi to determine do they have any signs of hypertensive retinopathy. It's really difficult to see the fundi, I know, at times, but can be worth doing if you can. As I mentioned, the ECG, there's 2 key things as family medicine consultants that we're looking at on an ECG in hypertension. The first is, does this person have atrial fibrillation? Because that's one of the common consequences of persistent hypertension. And the second is, do they have left ventricular hypertrophy? And there's a lot of ways of measuring left ventricular hypertrophy. I think this is one of the simpler ones, the Sokolov-Line criteria, where you add the S wave in V1 plus the R wave in V5 or V6, depending on which is bigger. And if the sum is greater than 35 millimeters, that's 3.5 of the big squares, then this person has left ventricular hypertrophy. So looking at this person here, if you look at V5, you can see that they have 1, 2, 3, 4, 4.5 big squares in V5, which is 45 millimeters. And then going to V1, you can see here that they have 1, 2.5. So 25 millimeters in V1, so 2.5 squares in V1, 4.5 in V5, 7 large squares, which is 70 millimeters, well above that 35 millimeter cutoff. And by definition, this person has left ventricular hypertrophy by ECG criteria, which, as you know, is a prognostic marker in hypertension.
Joe, could I interrupt you for a second? We didn't have the ECG there for the first bit when you were talking. Would you mind just going over that again?
Of course, no problem. This is just about the left ventricular hypertrophy, Molly, is it?
Yeah, just the ECG.
Perfect.
You were talking through it, but we didn't have the.
You see it. Perfect.
The actual ECG.
Can you see it there now, Molly? Can you see now? Okay.
Yeah, it's there now. Thanks. Yeah.
So I was just saying that when we do measuring the left ventricular hypertrophy, you add the R wave in V5. So counting this R wave here, we have 1, 2, 3, 4, 4.5 big squares. So that's 45 millimeters. And then if we go to V1, we have 1, 2, 2.5 big squares here. So that's 2.5 squares and 4.5 squares is 7 large squares when we sum them up, which is 70 millimeters. And that's well above the cutoff of 35 millimeters for left ventricular hypertrophy. So this person, by definition, has ECG evidence of left ventricular hypertrophy. Yeah, so at this stage, perfect. Thanks, Molly. So at this stage, we've diagnosed the person as hypertension and decided how severe it is. We've also looked for evidence of target organ damage with those tests. And the next question is really, what is their total cardiovascular risk? Because people don't just tend to have hypertension on their own. They may have hyperlipidemia. They may have had other previous cardiovascular events. So the first thing is, there's a lot of talk about risk scores, but it's important not to use a risk score if someone is already high risk due to some other conditions. And these are from the European Society of Cardiology guidelines. So if someone already has cardiovascular disease, such as they've previously had a stroke or a TIA, then they're already high risk. Or if they've had some sort of imaging that shows they've had plaque on their arteries. So they've had an angiogram and it said there's some plaque there. Even if it's not obstructive, they're already high risk. If they've had diabetes, again with signs of, for instance, diabetic nephropathy, or they've had it for a long time, they're already high risk. If they're very high levels of one risk factor, so total cholesterol over 8 and LDL cholesterol greater than 4.9, or blood pressure greater than 180 over 110, then they have very high risk factors, and risk scores don't tend to do well in identifying people who are at high risk. If they've just one risk factor high, they're already considered high risk because it's so out of the normal population range to have levels that high. People who've chronic kidney disease or familial hypercholesterolemia, if people have any of these, then you don't need to do a risk score. They're already considered high risk and you should treat their hypertension. If they don't have those and you want to assess their cardiovascular risk, you should use a validated risk score. And again, you may have different ones. Here we tend to use the QRIS-3 score, which is based on the UK population. There are American cardiology risk scores and European Society of Cardiology risk scores, but pick one that you're familiar with and that you are sort of aware of the advantages and disadvantages of a particular score, and that makes it easier to use. But just to the limitation of risk scores, I just want to highlight this man, a 40-year-old man, very elevated blood pressure of 182 over 110, very elevated lipids, no other medical problems. If we put these values into a QRIS-3 calculator, he gets a very low cardiovascular risk of 2.8%. I'm sure none of us actually believe this man has a low cardiovascular risk. His values are so abnormal, but it just shows you the limitations of risk scores and just to be aware of that fact when using them. So at this stage, as I mentioned, we know is the person hypertensive or not? Do they have evidence of target organ damage or not? Do they have any high-risk features in cardiovascular disease? We know from the history. And what is their total cardiovascular risk score? And then we can use this to try and make some decisions around treatment. So lifestyle changes are really important, also the hardest to try and implement and maintain. So reducing weight, using the DASH diet, reducing salt intake, increasing exercise and stopping smoking are all really important things in reducing blood pressure and reducing your overall cardiovascular risk.
Can I come in with a question there, Joe? Because it just fits right there. If you go back to that last slide, just one of our residents, Dr. Hanan, has just asked, which of the lifestyle modifications do you think will have more benefit on reducing the blood pressure? Would it be the DASH diet or the exercise? I suppose a combination, but in general, what do you think?
It's a good point. I think it's a combination. I think in many ways, if they can follow the DASH diet, they will reduce their weight and they'll actually reduce salt. So in some ways, that will achieve a lot, if you can get the diet right. Equally, reducing weight has probably the biggest numeric effect, but 10 kilos of weight loss is very hard to achieve as well. So, I think realistically, a little bit of everything is probably better than all of, a huge emphasis on one thing. So you're saying to people, a bit more exercise, stopping smoking, and trying to get your weight down a bit is probably more additive in getting blood pressure under control and improving their cardiovascular risk than saying, look, we'll just get your weight down by 10 kilos no matter what.
Okay, thanks.
So having talked about the lifestyle changes, I suppose the next question is, who should we treat with drugs? And again, this is from the UK guidelines, who suggest that anyone with stage 2 hypertension should be treated with medication. Anyone with stage 1 hypertension, that's a blood pressure between 140 and 160 systolic, or 90 and 100 diastolic, who also have evidence of target organ damage or other high-risk features like what we talked about before. In older people, they allow a little bit more of a lenient level. They say that if the blood pressure is greater than 150 over 90 and they're over 80 years of age, we should consider certainly treating blood pressure, but we may need to consider frailty and the multimorbidity in that. And young adults with stage 1 hypertension should be treated because they will have blood pressure for much longer in their lifetime and are more likely to have adverse effects therefore. But really they need to be in a specialist clinic because they're also more likely to have some cause of secondary hypertension that may be setting this off. So in terms of treatments, every guideline has a different approach to it. And I'm just going to take this European Society of Cardiology just as an example. They all use similar medications, which you'll all be very familiar with. The Europeans in last year, when they brought out their guidelines, suggested considering a single pill combination to start in most patients, or 2 drugs together at least in those with stage 2 hypertension, certainly, but almost all patients. So they suggest that we should start with an ACE inhibitor or an ARB in combination with a calcium channel blocker or a diuretic as a first-line treatment. Then if the blood pressure isn't controlled, the next addition is to add whatever drug wasn't there. So someone may be on an ARB with a calcium channel blocker and a diuretic. And if blood pressure isn't controlled at that stage, we're talking about resistant hypertension. Someone on 3 different types of medication for their blood pressure isn't controlled, has resistant hypertension. Probably the commonest cause is people aren't taking their medication. So really important to ask, are you taking your medication? Are they having side effects we need to address? And then if not, spironolactone appears to be the medication that is most beneficial in lowering blood pressure in someone who has resistant hypertension. Although obviously you can consider other ones such as other diuretics, alpha blockers or beta blockers. Why did they decide to go with 2 or more medications as first line? It was based on studies that show that most patients will require 2 or more drugs to control their blood pressure anyway. As you know, you get better effect with lower doses of 2 drugs than a higher dose of 1. There appears to be improved adherence as you reduce the pill burden by reducing the number of medications they're taking. But they do highlight, as you saw on the last slide, we have to have caution those who have borderline blood pressure, who are frail, of multimorbidity. This diagram here at the side just shows a study where they looked at adding on medication sequentially compared to starting with a combination therapy. And this light gray line here at the bottom shows that it took longer to achieve blood pressure control compared to starting with a combination therapy first line. So yes, after 3.5 years, both groups had the same level of blood pressure control, but it took longer for the people who were having therapy added on at each visit to achieve that blood pressure control. What's the target blood pressure? And again, every guideline has different targets. So again, I'm just showing you here the UK guideline target, which is that you should reduce the clinic blood pressure to below 140 over 90 in those under 80 years of age, and to below 150 over 90 in those aged 80 years or over. It's just using clinical judgment for people with frailty or multimorbidity. As you know, there's been other studies such as SPRINT, which have shown that reducing blood pressure even lower is beneficial, but it's very hard to achieve. And certainly across the world, the number of people who achieve blood pressure control is only around 1/3 of people with hypertension. And I think certainly in family medicine, by aiming to get blood pressure to at least this minimum level of control would be an excellent outcome. And then if possible, we can try and get it lower. And this is just a signpost that's famous in Ireland showing the different directions here where Tony Cox, who I think you know well, also lives. And I think it's similar with these hypertension guidelines, that they have many different ways of targets and of what medications to use. The important thing is that you pick one, you become familiar with it, and that you're happy to use it. I'm just going to briefly mention older people because I think it is very complex to manage hypertension in older people, and family medicine specialists are often the ones who are best placed to do so. And that's because of the multimorbidity associated that we see in older people, and frailty that can make it, the guidelines don't apply as well to them and makes it more challenging. There's certainly a benefit to treating older people with hypertension. These are studies looking at people over 70 years of age, and you can see very impressive reductions in stroke and heart failure and ischemic heart disease from treating blood pressure. So certainly worthwhile. The SPRINT study, which I mentioned just earlier, it was the most recent study to look at people who had high blood pressure and included older people and including people who had frailty. And they also saw that the intensive blood pressure control helped people at all ages, and even if they had frailty, they still benefited from having intensive blood pressure control where possible. I think part of the specialty of family medicine is adapting guidelines to the patient sitting in front of us, and this is just an approach that I tend to use. If someone has preserved function, if they're living their life as normal every day, I would treat their blood pressure as normal. If they've some loss of function but they're coping well, then you might tailor it. You might allow a little bit of a higher blood pressure or not be as aggressive with blood pressure medication. But certainly if someone is quite frail and it's, then we need to really perhaps reduce medications if they're already on them, if we feel their blood pressure has gone too low. If we are starting medications, we need to start on a low dose of the medication and increase it slowly and try and avoid more than 2 medications. And the other important thing is to try and keep the systolic blood pressure between 130 and 150, because particularly this group who are quite frail are prone to postural hypotension and therefore risk of fall. So we try not to get the levels as low in this group as we might otherwise do. This was a study published in JAMA last month, which showed that older people who had well-controlled hypertension, who were on 2 or more medications, it was possible to reduce the medications without the blood pressure worsening. So if you have someone who has a large amount of medication in polypharmacy, the blood pressure is very well controlled, it's possible to reduce medication often without having their blood pressure worsening, which may help them in managing their medications. I'm going to mention postural hypertension because I think that's one of the big problems we face in trying to manage. And it's also important to remember postprandial hypotension, which is where someone has had a big meal, the blood is now going to their gastrointestinal circulation, and because of that, their blood pressure drops. Also, you'll have people who will complain of feeling dizzy after a big meal who are hypertensive. It occurs in around up to 20% of older adult patients, and it's something we need to be cautious of. In terms of postural hypotension, they suggest measuring the blood pressure sitting, and then when they're standing for a minute, and then after 3 minutes of standing. And the official recommendation is a reduction in blood pressure of systolic blood pressure of greater than 20 or diastolic blood pressure of greater than 10 within 3 minutes of standing. The important thing we often don't remember that guidelines, blood pressure needs to be tolerated. There is no point in treating blood pressure if someone falls over and breaks their hip. And this is from the European Society of Cardiology guidelines, where they acknowledge that in some patients, the best BP may be higher than the recommended target. But coming back to our first point, a 10 millimeter reduction in mercury of blood pressure is associated with significant reductions in morbidity and mortality. And so any reduction in blood pressure is good, but it's important that the patient can tolerate it.
Joe, could I come in with a couple of questions that
perfect.
Come up? Or maybe do your summary first if you like, and then
good.
And then we'll come in with just some questions around drugs. Yeah.
So I suppose, just to remember, hypertension, it's really common. We all see it regularly. It's undertreated across the world by all specialties, but also sometimes overtreated in some individuals where they may be getting significant symptoms because of the medication. It's recommended where possible to use some out-of-office blood pressure measurements, such as ambulatory blood pressure measurement or home blood pressure measurement, to confirm the diagnosis. And the guideline as to who should be treated with medications is people with stage 2 hypertension or people with stage 1 hypertension and other risks. There seems to be an advantage to using single pill combinations if possible in terms of adherence and achieving blood pressure control. And certainly I think if we can aim to get the blood pressure less than 140/90, that's a good start. But you can try and go lower if you tolerate it. In terms of treating hypertension, a blood pressure less than 120 millimeters of mercury can sometimes lead to more symptoms, and just to be cautious if someone particularly is on it for a number of years and now they've become much older, they may not need as much medication. And the other important thing to remember is systolic blood pressure is just as important as diastolic blood pressure in terms of treatment goals. So Molly, do you want to?
Okay. Yeah, there were just a couple of questions just around the actual medications. So the first one was just a question from Dr. Mariam. Does the evidence prefer non-thiazide diuretics over thiazide diuretics if you're prescribing diuretic?
So the it's interesting. There's differences depending on what side of the Atlantic you're on. The Europeans tend to use thiazide diuretics, particularly hydrochlorothiazide. The Americans tend to use chlorothalidone, another type of thiazide diuretic, but there is more use of loop diuretics there as well. So the European guidelines tend to recommend thiazide diuretics as the medication. There's less side effects and just as good blood pressure control.
Mm-hmm. But both of them are as effective as one another. It's just from a side effect point of view.
Exactly. Yeah.
Exactly. Yeah. Okay. The other question, just you were talking there earlier about sometimes having to accept that you won't get proper full control, and quite often we don't, as we know in real life. So the question was just for how long should a patient be on 3 antihypertensive medications before you diagnose them, or before you say that they actually have resistant hypertension?
I think it's a really good question, Molly, and I think you'd wait at least 3 months unless their blood pressure was very high. If you know, so you had someone whose blood pressure was 180 over 110 and around 3 medications, then I think that's resistant. But someone whose blood pressure is 150 over 100 and on 3 medications, I would give it 3 months. And I think it's really important to query them about the adherence. I think it's so common. I saw a study from the UK in a resistant hypertension clinic where they measured the drugs and urine samples of patients attending the clinic. So these are people who are going to a clinic, particularly because they're resistant to high blood pressure, are being told they're checking their urine to see are they taking the drugs, and 70% of them weren't taking the medication. So, you know, I can only imagine what it's like in our clinics in Ireland and in Saudi Arabia. So I think adherence is the big thing to try and identify. But yeah, I'd give it a couple of months before I'd say that it's not responding.
Mm-hmm. And just one more question there. Sorry, there's a couple more questions coming in there now. So just one more, which is just asking, I think it's asking about doubling the dose of one drug as opposed to using 2 drugs. What's the difference with regard to the drop in blood pressure that you would get?
So it's really interesting. You get 4 times the drop in blood pressure from a low dose of 2 drugs as opposed to doubling the dose of 1. So it's quite a significant difference in terms of dropping blood pressure by using low doses of 2 different types of drugs as opposed to doubling the dose of 1.
Okay, and there's one other question here then, Joe, which is slightly different, not around the drugs as such. It's just asking for you to maybe comment on chronic kidney disease and hypertension and the control of hypertension, and when do you refer to nephrology?
Yeah, so it's a really good question because, you know, chronic kidney disease can both be a cause of hypertension and a result of hypertension. So I think in terms of treatment, the medications are much the same, and it's important to remember that you know, ACE inhibitors and angiotensin receptor blockers are protective in chronic kidney disease. You know, when we start someone on an ACE inhibitor or an angiotensin receptor blocker, an increase in creatinine of around 25% is acceptable. So you know, if someone started off with 100 millimeter or creatinine of 100 and went up to 120, I'd be happy enough with that. But equally, if it went from 100 to 160, I think they need to see a nephrologist about that. I think the other thing is if they have proteinuria, then they should see a nephrologist because they're more likely to have progressive chronic kidney disease. And then if their blood pressure is hard to control. So coming back to one of the earlier questions, sometimes the thiazide diuretics won't work as well in people who have chronic kidney disease, and it can be very hard to manage their blood pressure. Excuse me. So in that group, I would be, you know, they may need loop diuretics, which tend to work a bit better for blood pressure control. So again, I'd probably, if they're on 3 medications and not controlled, I'd probably refer them a bit quicker. And then apart from that, in Ireland, we tend, if their GFR had dropped to around 30 or was dropping quickly, you know, if it was going from 60 down to 50 down to 40 over a number of months, I'd refer as well. So I suppose in summary, if they've got proteinuria, if they're on 3 medications that's not controlled, if they have a rapidly decreasing GFR, or if their GFR is less than 30, or if they're younger as well. I think if you can't explain why this is happening, if someone is 50 and their GFR is only 40, then I think they need to see a nephrologist as well.
Okay. A few more questions coming along here now, Joe, if you don't mind, just around, because you're moving on to AFib next, I think, aren't you?
I can, yeah, but we can.
So we just finish up on maybe on some of the hypertension ones here. So a man is just asking, how frequently should we do an ECG for a hypertensive patient?
Yeah, so it's a really interesting question. Certainly a diagnosis. And then the guidelines don't come down very strongly on how often after that. If they have other conditions such as ischemic heart disease or heart failure, they would say annually at least. In other places, it can be very much dependent on how often you feel. The big risk we're looking for in ECGs are, as we mentioned, atrial fibrillation. So you may decide to use a pulse check, or the development of left ventricular hypertrophy. So if their blood pressure wasn't controlled, you might decide to do it each year. I think the other thing is these handheld devices like the little cardio device that will record ECG quickly on your phone can be very useful as well. I find it hard to detect irregular pulses. It feels like my final medical exam every time I check it. So they can be useful for that. So there's no strict guideline on it. It's based on clinical need. But if they have other cardiovascular conditions, I check it annually. And then in people who have just hypertension alone, I would probably do it dependent on clinical needs, such as an irregular pulse or a change in symptoms or something like that.
Okay, and just two more questions then on ACEs. So the first one is just asking, can we use ACEs as primary prevention in a diabetic patient, even if the albumin creatinine ratio is normal? That's the question. Second one is from Dr. Saad Al-Battal, who's a very esteemed colleague of ours, and he's just thanking you for the talk, Joe. And he's also asking, Saad, do you want to unmute and ask a question yourself, actually, if you'd like?
Yeah, hi. Thanks guys for giving me the opportunity. I don't know if my voice is clear or not.
Yes, good job. Good job.
I would love to hear the Dr. Joe comment about the elevation in creatinine after commencing the ACE inhibitors. The guidelines mention that increment in 30%, that's expected in certain patients. But that's from the baseline. I would love to hear Dr. Joe comment about that. Thanks again for giving me the opportunity.
Thanks, Saad.
Thanks, Dr. Saad. So I'll maybe deal with that one first. So I agree with you. Guidelines are 25 to 30%. They say it's acceptable, and as you know, Dr. Saad, that's because the glomerular filtration pressure drops, and because of that, we should see the creatinine rising. And in fact, it's a good marker is the patient taking the drug. So it's not the rise in creatinine we see with ACE inhibitors of that level is more due to the protective effect on reducing the pressure in the kidneys rather than a true sort of kidney failure. I think it's important when we see it to think, is there any other thing that might be making that creatinine go up? So for instance, someone taking non-steroidal anti-inflammatory drugs for their osteoarthritis, or have we dropped their blood pressure too low? Has that happened as well? I had a man actually only last month his blood pressure had gone from 135 over 75 down to 107 over 65, and his creatinine went from 180 to 280. And when we stopped the calcium channel blocker and the blood pressure came back up, his creatinine came back down again. So I think it's not something to be worried about, but something to keep an eye on, not let it rise too much. So as you said, 25 to 30%, I think is as much as we tolerate, but equally also think, is there other reasons why that creatinine may be going up that we can correct, such as non-steroidal anti-inflammatory drugs? I hope that answers the question, Dr. Saad.
So I just have a question also from Dr. Abdulaziz Al-Matari, who's another colleague of ours down in the Family Medicine Academy in Qasim, actually, long way from Riyadh, 5 hours drive, I know, because we've done it. And he's just saying that he can't speak at the moment because he's actually driving and listening. But he's just asking particularly about what's more appropriate around cardiovascular risk assessment for the Saudi population.
It's a really good question, I think, because one of the big problems with all these risk scores is that they are obviously developed in populations, whether it's in America or in the United Kingdom, that are very different to the population where they are being applied. So for instance, as you mentioned, Molly, I do a lot of global health work, which is based in Malawi in Africa. There's no risk score that has been developed for that part of the world. So it's really important to consider that when we're looking at risk scores. The QS3 calculator does have an ethnicity built into it. Now it is based on UK population, but it does have you can select different ethnic groups in it. And I think it's just not to be beholden to the risk calculators. You'll use them as a guide, but I think family medicine specialists are really good at saying, yeah, that confirms what I thought. This person is high risk, and I can use that to help guide them towards that they need to change their lifestyle and need to start medication. But I would pick one that you're familiar with, that you will know what the population was it was derived from and what its limitations are, and then use it as a guide rather than as a rule to decide when people should have treatment for whether it's lipids or whether it's hypertension.
Mm-hmm. Okay. Another question here, just again around the drugs, Joe. Yeah. So Dr. Noon is just saying sometimes that you do still find patients who might be on beta blockers from way back when, and how do we titrate them or how do we manage them?
Yeah. So again, a really good question. I'm sure everyone you go through phases in medicine where something is all the vogue, and then all of a sudden it falls out of fashion. And beta blockers and hypertension is one of those things. So my approach is, if someone's blood pressure is well controlled on a beta blocker, I don't change it. Or equally, they may have an indication to have a beta blocker, such as they have atrial fibrillation, or they've had a myocardial infarction before, and the beta blockers are very relevant for them. So certainly if they're well controlled, I don't change it. If we're starting it because they need to have a beta blocker for one of those indications, and we're also trying to manage their blood pressure, obviously I titrate it against the blood pressure, but also the heart rate. So, I'd let their heart rate get down to around 60 if they can tolerate it, but I wouldn't be pushing it much lower, because they tend to get quite symptomatic once they get beyond that level. So the reason the beta blockers fell out of fashion in hypertension is that they were found to be not as effective at reducing blood pressure compared to the other agents. So there's nothing wrong with them per se, but you just have to get to such high doses to get the blood pressure down. But still very useful to use in certain situations like atrial fibrillation or ischemic heart disease.
Okay, thanks, Joe. I think that's it for the questions for now. We might let you get on and finish your talk. Okay, thank you.
It's great to have such interactivity. So thanks everyone for listening in. I'm going to mention atrial fibrillation briefly, and I'm going to talk about the 2020 guidelines on atrial fibrillation, which were just released in September from the European Society of Cardiology. And there's a really nice mnemonic, I think, that's useful, and it's CC to ABC, about how, if you see someone with atrial fibrillation, how to consider them. So the first C is to confirm the diagnosis. And as we know, you need an ECG to confirm the diagnosis. The big change this year in these guidelines was that it didn't have to be a 12-lead ECG to confirm the diagnosis. They also suggested that 30-second single-lead ECG was sufficient to confirm a diagnosis of atrial fibrillation, particularly useful in people who have paroxysmal atrial fibrillation. And they're talking about devices like this little cardio device, which the person can hold, and it'll record a 6-lead ECG on your phone that you can use as a record, and is approved now by the FDA in the United States as being sufficient to make a diagnosis of atrial fibrillation. Just a reminder as regards atrial fibrillation and ECGs. So ECGs are, and I'm sure we've all seen these interpreted ECGs, and they tell you this person's had a myocardial infarction and they're feeling perfectly fine. So ECGs tend to overinterpret things. So this was an ECG that was interpreted as being atrial fibrillation. And you can see here, if you look at these lines here, they're very squiggly and it's hard to see is there a P wave in it. So the best lead to look at is often V2, or lead 2, sorry. And you can see here there's quite clear P waves. So the important thing is, if you have an ECG that says this person has atrial fibrillation, do look and make sure that they do have atrial fibrillation, because ECGs will overcall it sometimes, and you may start treating someone when they don't need to be. This next ECG, again, this is a patient in our practice. The ECG came back as seeing atrial fibrillation. To us, we can see quite clearly that there's nice P waves here and here and here. And I think what put this machine off on the wrong sort of thing was this sort of artifact down here at the bottom where the patient moved, or there was some tremor, and you can see it's sort of very coarse and can look like fibrillation lines. So the computer overcalled this and thought this was atrial fibrillation. So yes, they're a good guide, the ECG interpretations, but they're not the be all and end all. So I suppose in terms of ECGs and atrial fibrillation, what do we look out for? Well, I think there's two things. The QRS complex tends to be easy enough to spot. It's the big thing in the middle of the ECG. And then between each QRS complex, there has to be a T wave, because if you have a QRS complex, which is depolarization of the ventricle, you have to have repolarization of the ventricle. So if there's only one a wave in between two QRS complexes, that has to be a T wave. So if there's only one, that's what it is. If the other thing that you tend to notice, obviously, is that it can be irregular. So you get a irregular baseline. You can see the distance here between the QRS complexes is different almost for each beat. You can sometimes see these very fine sort of fibrillation waves. So it looks like a sawtooth is what they talk about at times as well. And the other thing that can be a hint is that the QRS complexes tend to be of different heights. And that's because we're getting different amounts of conduction of electrical activity down to the ventricles. And that not only helps guide us that this is atrial fibrillation, but also reminds us of why it's hard to measure blood pressure in atrial fibrillation. Because if you measure the blood pressure on this QRS complex, as opposed to this one, as opposed to that one, you're going to get different blood pressures. So in atrial fibrillation, measuring blood pressure is often about getting an average over a couple of readings, such as you might get an ambulatory blood pressure monitor. It's a very inexact science, but you will get different blood pressures from beat to beat with atrial fibrillation. So the important thing is, you look at the top of the ECG. If it tells you that it's there, that atrial fibrillation is there, look and make sure that you agree with that point as well. And this is just a reminder about an ECG for atrial fibrillation, which is almost looks like sinus rhythm. And this one almost caught me out because it looked like, oh, that looks fine. But if you look, there's only one wave between two QRS complexes, which has to be the T wave. You can see here. So if you can only see one wave, then that has to be a T wave, and then we're talking about atrial fibrillation. So just be careful. That's that one. So that's the first C, was to confirm the diagnosis with an ECG. The second C, in terms of when you're diagnosing someone with atrial fibrillation, is to characterize it. And for this, they have 4 S's. The first S is the stroke risk, which is a CHA2DS2-VASc score. The second S is symptoms. Does the person have any chest pain or dyspnea or palpitations or fatigue? The third S is the severity of the atrial fibrillation burden. And I think in primary care, we'd be mostly talking about permanent atrial fibrillation. But obviously, people can also have paroxysmal atrial fibrillation, so they may have it intermittently. And the fourth S they've called substrate severity, which is really about identifying things that may have precipitated atrial fibrillation, such as rheumatic heart disease, or hypertension, or heart failure, or diabetes. So it's 4 S's. And I think in terms of how that's done, obviously we can take a medical history, looking at what symptoms they have, asking about lifestyle risk factors, measuring the blood pressure and heart rate. We can calculate the CHA2DS2-VASc score, and we'll talk about some of the calculators later. And then people with atrial fibrillation, they need an ECG, obviously, to confirm it. A renal profile, because that will look if there's any signs of any kidney disease that may cause it and may affect some of the medications. A full blood count, because we may be putting them on anticoagulation, and therefore we need to make sure they're not anemic. Thyroid function tests, because hyperthyroidism is a precipitating factor. Then looking at other cardiovascular risks, such as a fasting glucose or HbA1c to check for diabetes, lipids. And then an echocardiogram is recommended for people with atrial fibrillation for 2 reasons. Firstly, because a third of people with atrial fibrillation will have heart failure, so it's important to check is there any evidence of heart failure. And secondly, the valvular heart disease, which can be associated with atrial fibrillation, and particularly rheumatic heart disease. It's important to seek that out and determine if that's there, because that may also influence your anticoagulation choice. So that's the diagnosis part of it. So you confirm with the ECG, characterize it by looking at the stroke risk, the symptoms, the severity of the atrial fibrillation, is it permanent or paroxysmal, and then the substrate severity, which is, do they have other conditions such as hypertension or diabetes or valvular disease that maybe make it worse. And then once you've done that, you have to consider the ABC. And the first A is anticoagulation. And here they talk about that we should consider an oral anticoagulant in all atrial fibrillation patients who have a CHA2DS2-VASc score of 1 or more in men or 2 or more in women. That's why I have these twins here, number 1 and 2, just as a reminder. Now, the European guidelines suggest considering a NOAC first line, and I'd be interested in talking to the colleagues in Saudi Arabia about is that the same in Saudi Arabia? Because there is a caveat there with that you cannot use a NOAC in someone who has a mechanical heart valve or has moderate severe mitral stenosis, which is obviously more common in people with rheumatic heart disease. But we should certainly consider some form of anticoagulation, whether it's warfarin or a NOAC. And then we should also look, is there any modifiable risk factors for bleeding? Because we know that our biggest fear is that someone will bleed on anticoagulation. And I'll just mention the Haslet score in a minute, which is a useful reminder of what might be things we could correct that would that might increase the risk of bleeding. And finally, the other reminder they have is that antiplatelets such as aspirin or clopidogrel are not of benefit for stroke prevention in atrial fibrillation, we might use them for things like ischemic heart disease, but either someone goes on to anticoagulation or they don't in terms of preventing stroke and atrial fibrillation. Putting someone on aspirin because we don't think they should go on anticoagulation isn't of benefit. That's the anticoagulation side of it. I mentioned there's a number of calculators, and this is just one that I think is easy to use. It's the American College of Cardiology Anticoag Evaluator, and it is very quick. It guides you through the questions. Even if you select a drug, it'll tell you what the dose is. It'll give you the risk reduction. It'll guide you as to the creatinine clearance. And I think of most benefit, it'll generate this text here, for instance, which guides you as to, which you can copy and paste into your clinical record, which shows you what was the person's CHA2DS2-VASc score, what is their renal function, what is the risk of bleeding, what is the therapy guidance, and then you can select whether it's warfarin or NOAC, what is the dose that would be of benefit for them. So it's a useful tool, very quick to use, and as I said, you can then, it generates data for your patient record as well. You may have other tools in Saudi Arabia that may be of benefit also. I'd mentioned the HAS-BLED score, and you can see that's calculated in the American College of Cardiology app. It's just a reminder of things that can increase the risk of bleeding that we may be able to correct, such as hypertension. If they have persistently high blood pressure, we should treat that because that increases the risk of bleeding. Or for instance, someone taking a non-steroidal anti-inflammatory drug for their osteoarthritis, we might decide to change or stop that because again, that increases the risk of bleeding. So again, it's not, some of these aren't correctable. If someone has a high serum creatinine, well, we may not be able to do something about that, but it's important to think about these things that may increase the risk of bleeding and may help alter the choice of anticoagulant. So that's anticoagulation. Then the B is for better symptom control, and for most people, I think particularly in primary care, that will be about rate control. And what's really interesting from this guideline is that they highlight they're still not clear what is the best rate for atrial fibrillation. So we talked about getting heart rates down to 60 in the last talk if someone's on a beta blocker and trying to control their blood pressure. In atrial fibrillation, there doesn't seem to be any benefit to getting the heart rate down too low. In actual fact, the guideline says a heart rate of less than 110 beats per minute is fine for someone in atrial fibrillation. Now, the study that's based on, which is the RACE study, that actually had an average heart rate of 90 beats per minute in people with atrial fibrillation. So most guidelines say, look, we'd aim for a rate of around 90 beats per minute in someone who has atrial fibrillation. And if they've persistent symptoms, you might try and get that rate lower, maybe down to around 80 beats per minute. But we don't need to drive it down to 60 or 50 beats per minute to make them feel better. And it doesn't improve their prognosis to get their rate that low. In terms of rate control, there are two main drugs that we tend to use, a beta blocker and digoxin. You can use them alone or in combination. The beta blocker tends to be better at controlling the rate. Digoxin is good at controlling the rate when you're at rest, but when people start walking or mobilizing, then it's not as good as controlling the heart rate when they start to walk. And so therefore they may get palpitations when they're walking more. The third option that you can sometimes use is verapamil or diltiazem. But the only thing with that is you have to be sure that the person has a normal ejection fraction on their echocardiogram, because verapamil and diltiazem reduce the contractility of the heart, as you know. So therefore, if they have a low ejection fraction, you'll worsen their heart failure. So beta blockers and digoxin are safe to use in almost everyone who has atrial fibrillation. But verapamil and diltiazem, you need to know what their echocardiogram showed before you would use that drug. I'm just going to briefly mention rhythm control, which is trying to convert someone back into sinus rhythm, whether it's with a cardioversion or with an ablation. And this study from 2002 is what changed the perspective on this, because what they found was there was no benefit in terms of prognosis, in terms of rate control, which is putting someone on anticoagulant and controlling their heart rate, compared to rhythm control. And obviously there's a lot of risks in terms of ablations and the risks of procedures. So they're not as widely used now as what they would have been before because of that. But there are groups who do benefit from rhythm control, and certainly it'd be worth, I think, a cardiologist seeing someone who was quite young, and that's less than 65 years, I've said here, who has new onset atrial fibrillation, because they may benefit from it. If they have persistent symptoms despite having a good heart rate, they may benefit from trying to convert it to sinus rhythm. Obviously, if they've got reversible causes like hyperthyroidism, if they're very symptomatic in paroxysmal atrial fibrillation, they tend to do very well. And if they've quite problems with heart failure, people with heart failure sometimes can't tolerate atrial fibrillation very well because they need the contractility of the atria to try and keep the heart moving well. So sometimes they may need cardioversion or ablation to try and improve their symptoms. So it's not that no one should get rhythm control, but it's just not as common maybe as what it might have been before, because it doesn't improve prognosis, but can be very good at improving symptoms. Just to remind us how ablation works. So what we know is that most of the atrial fibrillation arises from around the pulmonary veins. And what they do is they burn the tissue around the pulmonary veins, which stops the signals that start atrial fibrillation from getting out. And what they've found is that the current techniques we use, 80% of patients will be 1 year free from symptomatic atrial fibrillation or symptomatic atrial fibrillation. So it's very good for symptoms if it works, particularly if it's paroxysmal, but doesn't change prognosis. What's interesting, I think, from a family medicine's perspective is, as we know, I've said those pulmonary veins, and you'll sometimes have patients come into you and say, oh, doctor, I'm fine until I lie down at night, and then I get all these palpitations. And what's actually happening there is that when you're sitting up, your pulmonary veins are nice and they're, the blood is all mostly down in your feet. And when you lie down at night, the blood comes back up into your lungs and it distends the pulmonary veins, and it can actually set off your atrial fibrillation. So if you have someone coming into the clinic saying, I get lots of palpitations when I lie down at night, just be suspicious that they may be developing runs of atrial fibrillation because their pulmonary veins are being distended. And this is just a reminder that the risks of the catheter ablation are quite significant, and they include death, injury to the esophagus, tardive tamponade, and phrenic nerve palsy. So it's not a procedure to be undertaken lightly. So that's the B, which is better symptom control. So that's mostly about rate control, and then rhythm control in a small number of patients who may benefit. And the final C is really the domain of family medicine, which is managing comorbidities and cardiovascular risk management, because we know that people with atrial fibrillation tend to have a lot of other conditions, and if we manage these better, they will have better outcomes. So this is just one example, and on this slide I just want you to look at the grey areas on the pie charts. And this was a study that looked at the effect of weight loss on atrial fibrillation. And the group that lost less than 3% of weight, there was 25% of those were atrial fibrillation free at the end of the study. The group that lost 3 to 9% of the weight, 32% of those were atrial fibrillation free at the end of the study. But the group that lost more than 10% of their weight, 52% were atrial fibrillation free at the end of the study. So coming back to what we talked about earlier, if we can achieve this sort of stuff, probably better than any drug that we have to manage atrial fibrillation to lose weight. But as we all recognize, it's easier said than done. The other comorbidities you'll all be very familiar with, and I'm not going to go into them in detail, but these are the common comorbidities we see with atrial fibrillation, from overweight, obstructive sleep apnea, physical inactivity, glucose control, smoking, and not to forget immunizations, because influenza vaccine, and I'm not sure is it widely used in Saudi Arabia, but very beneficial in improving outcomes in cardiovascular disease also. I'm going to just briefly mention, again, older people, similar to what I did, hypertension, because I think one of our biggest concerns in family medicine is about someone falling and hitting their head when they're on an anticoagulant, and the effect this might have in terms of bleeds. So I think the first thing to acknowledge that falls are common in older people. This study found that 1/3 of people over the age of 65 had at least one fall in the preceding year. And this other study found that in people with atrial fibrillation who had a history of falls, they had twice the risk of intracranial hemorrhage compared to people of the same age who didn't have a history of falls. What was interesting about this study was that they found that the risk didn't change. The risk of the intracranial hemorrhage didn't change if the person was on warfarin, aspirin, or no antithrombotic therapy. So in other words, the risk of the intracranial hemorrhage was related to the fall rather than to the actual medications they were on. And this other study suggested that you'd have to fall 295 times in 1 year for the risk of a fall to outweigh the benefit of warfarin in reducing the risk of a stroke. Now, I think it's a little bit simplistic, because we all know you only need one bad fall for you to have a bad intracranial hemorrhage. But it's just, I think, it can be reassuring if you have someone who has a mechanical fall that you can easily identify why they had that fall. It's certainly worth considering anticoagulating those people anyway, because the risk of stroke, of ischemic stroke in atrial fibrillation is quite high. So I'm going to summarize this here again, just as The diagnosis of atrial fibrillation is the 2 C's. That's confirm it using the ECG, characterize atrial fibrillation then by looking at the stroke risk, what symptoms the person has, what's the severity of the AF burden, is it paroxysmal or permanent, and what is the substrate, what are the comorbidities such as blood pressure or diabetes that you can identify that might have caused this person to get atrial fibrillation. And then the second part of it is in terms of long-term management, it's considering anticoagulation and ensuring that if people are on it, that it's appropriate that they stay on it. And if you had decided not to put them on it at one point, should that change later on? So the commonest scenario there is someone who might have been quite young. They were 55 when they first diagnosed with atrial fibrillation. Now they're 65 or 70. Their cardiovascular will have increased and they may now benefit from anticoagulation. Better symptom control is mostly about controlling the rate, heart rate, although some people have benefit from rhythm control. And then finally, our role is about controlling comorbidities such as hypertension, diabetes, and other cardiovascular risk factors, and factors such as weight loss to try and improve the outcomes in people with atrial fibrillation. So thank you.
Okay, have to catch my breath after that. Quick question there. Please comment on PAF.
Yeah, so it's a really good question. So it's a tricky one. I think, you know, from a family medicine point of view, these people mostly end up in cardiology clinics because the decision about anticoagulation is more difficult. The current guidelines suggest that, you know, someone who has paroxysmal atrial fibrillation should be treated in terms of stroke risk the same as someone with permanent atrial fibrillation. But what's changed lately is things such as the Apple Watch, where you can now be picking up atrial fibrillation of a few seconds in duration, and we may find a lot of us have this sort of short duration. So I think certainly refer to your local internal medicine specialist or cardiologist. The decision really is, does this person need anticoagulation, or would you go down a rhythm control strategy and use something like either drugs or ablation to try and manage the paroxysmal atrial fibrillation?
Okay. So I don't think we've no more questions here at the moment, Joe. I have to say I learned a lot there. I'm just wondering if anybody has any questions, if they'd like to unmute and ask. I know Dr. Aisha, I think, is with us from Saudi Commission. I don't know if she has anything she'd like to ask. Or Dr. Rizaldine is one of our trainers. I see him here. Sorry, there are probably other people I should be mentioning that I'm missing here. Okay, somebody's just asked, when would the European Cardiovascular Guidelines recommend NOACs? Well, they're saying without evidence of atrial fibrillation, actually, which I'm not sure if that's.
Yeah, it's really only if they don't have evidence of atrial fibrillation. It's really only for.
Hello.
Oh yeah.
Hi, sorry for that. I'm not sure. The question wasn't very clear. What I meant was the suspicion is high for atrial fibrillation, or actually paroxysmal atrial fibrillation. Would you? Is there any mention in the guidelines on when to start it until we actually get them to the cardiologist, if they're at the rural area or something like that? Thank you.
Okay. Yeah, I understand now. Thank you. Yeah, they would say that you should have a confirmed diagnosis first. So they would say you need to have some ECG evidence, either on a ECG that you've taken. As I mentioned, the little cardio devices, I sometimes say to patients to use them, and they can record a strip, because you can have them in the clinic, or sometimes they'll buy them online themselves, or on a Holter monitor. So I wouldn't start an anticoagulant without a definite ECG evidence at some point showing that they have atrial fibrillation.
And what they also do here, particularly for the paroxysmal, Mariam, is they'll send people home with a loop monitor, which they'll keep for maybe 10 days to 2 weeks, you know, so that any event or anything that feels a bit odd to them at all, they just press the button, it'll record. And indeed, if they don't pick it up on that, they have these little ones now that they can just implant under the skin, a little implant, which they can leave in for months or even years, I think now, Joe, isn't that right? But obviously that's when you get as far as the cardiology clinic.
Exactly,
you're talking about before that, yeah.
No, I think you're right. Yeah, it's amazing 2 years they can leave them in for now. But yeah, you need to have some evidence of it.
Yeah. Okay.
I'm sorry, just one last question. Do you also start NOACs if a person or a patient is cardioverted in the emergency department, and how long? Thank you.
So again, it's a really good question, and I think it often comes down to a specialist advising on it. So the guidelines would say that after a cardioversion, someone should be on anticoagulant for at least 4 weeks. So certainly, even if it's successful, they shouldn't stop it before then. Now, the evidence suggests that in actual fact, these people are still at high risk of getting atrial fibrillation again, and it can be silent. So they could go back into atrial fibrillation and they won't know it and you won't know it. So some guidelines recommend that the person should stay on anticoagulants indefinitely, whereas some cardiologists will say, no, they will repeat the ECG and maybe do a 24-hour ECG monitor after a month, and if that's negative, they will stop it. So it varies from specialist to specialist, to be honest, about when they stop it. And some will continue it long term, some will stop it after a 24-hour ECG monitor, and some will just stop it after 4 weeks if the ECG is still in sinus rhythm.
Great, thank you.
Thanks.
Okay, so any more questions? I think we've covered all the questions that came up in the chat, Joe. And now all you're getting is compliments here, people thanking you for the very informative and comprehensive update and presentation, which I would echo completely. I've learned loads today.
Thanks very much.
I'm delighted that I was here to hear all that, and I'm definitely going to have a look back on the slides now when they're up in the LMS, because there were a few things there that I was about to take photographs of, and then I said, oh, it's okay, I can look at them later. So, and I think probably everyone is the same. So unless we have any other questions, I think, it's getting late there inside. It's not so late for us, but it's after 7 p.m. there. So Vicky, unless you had anything you wanted to say, or have you any?
If the trainers, if you have not registered for the masterclass this coming Thursday, please do so. Don't miss the session.
Oh yeah, sorry, I should
very
echo that.
entertaining.
Tony and myself have that prepped, and we're looking forward to seeing just our trainers. The trainees, you're off the hook for once. The residents, it's just for trainers only on this Thursday. So we look forward to that. So just a big thank you to Joe. Joe, I know you're very busy in practice, and thank you so much for sneaking off away from your practice to do the session with us this afternoon. It has really been really informative and really helpful. Really appreciate it.
And thanks everyone for being so interactive. It's great to have people. It's hard on this forum, so it's a real credit to everyone to have had so much interactivity during this. So thank you.
Thanks a lot. Okay. Thanks everyone. See you soon.
Thanks,
Bye.
Thanks,
Bye,
Joe.
Brian. Bye, Vicky. Bye, Joe. Thank you.
Bye, everyone.
Bye, everyone. Bye.